And now we move on to our last talk of this webinar, and it gives me great pleasure to introduce Dr. Ben Fox. Ben is on the REUK Council with me, and he was on the AAGBI Board of Directors, where he's contributed to several national guideline documents. He's very passionate about regional anaesthesia. He's co-authored BAD's Handbooks on spinal anaesthesia for day surgery and upper limb nerve blocks. He was also the program director for the regional anaesthesia master's degree and has taught on many courses nationally and internationally. Ben, it's a great pleasure to hear you talking to us about implementing spinal anaesthesia, ambulatory spinal anaesthesia in 8 practical steps. Thank you.
Thank you, Amit, for the warm welcome. Yeah, hi, I'm Ben. I'm basically going to go through an infographic that we put together just to kind of really act as an entry for this type of modality. In terms of who I am, why am I talking to you, affiliations, or if I've been receiving money on the side. I'm the course director of the Regional Anaesthesia Master's degree. I have contributed to the Synthetica Handbook, which Robbie's already referred to. I've also received honorarium from Synthetica, so sold out. I have co-authored the British Association of Day Surgery Handbook on Spinal Anaesthesia, and I'm on the RAUK board. So what am I going to talk about? I'm basically going to go through this. So this is available on the RAUK website. Now, some of you would think this guy's an idiot because from the poll that you did with Amit, some of you are already doing this. So you might look at this and go, he's using way too much. This is meant to be like an entry just to help people. And then you can then refer to the booklet and also Robbie's talk to try and like get your practice to where you want it. So the main message for my talk is going to be keep it simple. Just keep it simple. I can do it and I'm an idiot, so it's idiot proof. First point, I'm asked quite a lot, how do you convince patients for this particular technique, spinal anaesthetic? I would say I don't try to convince, I try to just give the options, and Will Griffiths gave this in his talk a bit earlier on. You give the patients the information. You may well tip the scales in terms of what you think is your opinion of the benefits for that patient, but I'd never try and be a used car salesman. The secret, I think, is actually getting the surgeons and your pre-assessment staff on board. And that basically allows us to plant the seed, or this is the PIP, of that thought of the anaesthetic much earlier on in the patient journey. So in outpatients, if they're given a wide range of options that they can perhaps potentially have, they might start thinking about it. I think you're on a hiding to nothing if you try and convince someone or gang press someone into having a particular anaesthetic on the morning or the afternoon of surgery. What kind of operations are we actually doing with ambulatory spinal anaesthesia? This is a word cloud, and you're probably quite familiar with word clouds. The size of the font is how popular something is. This is the last 100 spinals we've done in our day case unit, and you can see the kind of regular players that are coming up. So cystoscopy and arthroscopy are kind of front and center. But you can see all the weird and wonderful things that we've also been doing with spinal anesthesia as well. Coming back to the conversation that the surgeon puts to the patient early on, when we first started talking about this webinar, I kind of had this idea, it's not a novel idea, but I had this idea for at least my department of producing a little anesthesia in a nutshell guidance so that surgeons just could kind of make some form of reference in terms of the anaesthetic options. Now, don't worry about all the details there. I've actually put it on my Twitter account, so if you have a look, you'll be able to see the full detail. This is just kind of like the nuts and bolts of it. This kind of gives you a bit of an idea of the information that perhaps a surgeon can tell patients that might kind of convince them of a particular technique for their anaesthetic, and it plants that seed nice and early on. So we say that we've managed to get some patients on board, they want to have a spinal. What about the technique? How are we actually going to put our needle in? As I said right at the beginning, keep it simple. So whatever you're most comfortable with, most anaesthetists I see like a sitting spinal, so just sitting spinal, the orifice of the needle, just have it facing cephalad, and then just lay the patient supine. With the doses I'll be talking about, you don't have to do any weird and wonderful positioning of the patients to kind of coax it into action. In terms of the orientation of the orifice, this is a nice little video that basically shows that the injectate, when you inject normally, it's along the axis of the needle. It doesn't do this lovely little kind of like right angle towards the nerve. So you can't just angle it to the left and it's just going to do a right turn or left turn. Yeah. Now, some people say, I don't want to do a spinal because of the time it takes. This is a setup that we've got here in terms of getting patients set up for having a spinal anaesthetic, a little video that I put together. But not all spinals are created equally. So even though the setup here is quite nice, and we get this 5-minute, 30 seconds, you sometimes see that the spinal itself doesn't go to plan. We've got some patients that we want to put a spinal in. We've actually got the needle in, so what drug do we do? In terms of the infographic, what we've put up here is just 2 doses, just as a kind of, as I said before, an entry level. So we've got 5 mils of 1% chloroprocaine, that's 50 milligrams, and we've got 2.5 mils of 2% heavy prilocaine, which is 50 milligrams. And what I'm going to do in the next few slides is talk about the dose, and also you'll see here I've got expected ambulation, and we'll talk about how we've kind of come up with those figures. So hyperbaric prilocaine. This is some data that I collected with one of my colleagues from my hospital a few years back. 82 knee arthroscopies. We looked back retrospectively, so it's almost like a kind of an audit type project, and we looked at the median dose, and it was 1.7 mils of 2% solution, so 34 milligrams. Now note, this was with fentanyl, which I stress is an off-label use, but that's the kind of where colleagues in my department were at with this. The median time from spinal to discharge was 3 hours in these patients. Now note, there is a wide range here from 1.5 hours, which is pretty impressive, to 6 hours. Now, those times have been shown in literature. So Campanovo, in one paper where him and his team were looking at 40 milligrams heavy prilocaine, 60 milligrams heavy prilocaine versus 60 milligrams plain prilocaine. And if you get the data for the 40 milligrams heavy prilocaine, in terms of spinal to discharge criteria, was 3.5 hours, which is pretty good. And it kind of almost follows our data as well. Now, this is a really lovely paper by Emmanuel Guntz and colleagues, and they did a study for the ED50 and ED90 of heavy prilocaine for knee arthroscopy. And they found the ED90 was 38.5 milligrams. And in the second part of their study, they used 40 milligrams of heavy prilocaine all by itself. And they found 2 things. One, in 4 patients, they needed some form of supplemental analgesia for the tourniquet and for the scopes. So this is why I kind of just pushed up this entry-level prilocaine to 50 milligrams. And also the other point to raise is the average duration was pretty much in keeping with our data and also Campanovo's data. If we move on to chloroprocaine, this is also data from our department. This was presented at ESRA back in 2014. This is really when chloroprocaine was kind of first getting onto the market in the UK. So 57 knee arthroscopies, and the dose was 40 milligrams. We found that the median time from spinal in to ambulation was 2 hours, with the range there 1.5 to 2.5 hours. 3 patients had pain with this, and 1 patient needed to be converted to a GA. Interestingly, I was the guy that did the spinal that got converted to the GA. So I said I'm presenting something that's idiot-proof, and that's kind of evidence about me being the idiot. In terms of other data, Campanovo, who was looking at chloroprocaine versus bupivacaine 10 milligrams, with 50 milligrams of chloroprocaine, they found from time of spinal to discharge was 2.5 hours. So one question that I've had a few times is, well, how does this all compare to general anaesthetic? Surely a quick general anaesthetic's quick in terms of time from anaesthetic to discharge. if we have a look at a list that is going on regularly in my hospital, so every other Tuesday morning we have a knee arthroscopy list with one particular surgeon. It's relatively the same theatre team, it's the same environment, so same setup. And this is going to reflect real life practice. So this isn't a study where someone's trying to get people out of the bed. This is kind of when the bosses aren't really looking. So don't necessarily judge us in terms of this, but it should give a nice comparison of the GA versus spinal. The range for the GA was from time of spinal, so this includes the surgical time and recovery time. Time from spinal to going home range from 3 to 7.5 hours. Now, if we look at the spinal group, it's pretty similar, 3.5 to 8.5 hours. Now, I know you're thinking, God, what are they doing? But this doesn't take into account anything in terms of travel arrangements, people waiting for cars. And actually, you can see that the mean difference isn't that, well, the difference between the two means isn't that much. It's an hour in it. So when people say spine is going to take ages, it's going to wear off, it's not going to wear off. Well, it's not that bad. And if you've got the GA the proponents saying, well, an hour is a lot of time, well, actually, I know Robbie's, the surgeons that Robbie works with, copies of one of the, well, doesn't copy, but does the same thing as one of the surgeons I work with, in that he doesn't do a follow-up appointment for the patients that have had a knee arthroscopy. He takes them on a little tour, like an underwater documentary of the knee, shows the problem, shows what he's done to it. The patient gets that information there and then, and he doesn't schedule an outpatient appointment. Whereas the GA patients, they all come back a few weeks later, and that even will have an impact on the environment, as per Will's talk earlier. So drugs, keep it simple. 50 milligrams chloroprocaine, as Robbie said, licensed for 40-minute operations, and we said 2 hours in terms of looking at ambulation. And then in terms of prilocaine, licensed for 90-minute operations, 50 milligrams, so 2.5 mils. And ambulation, you're looking at somewhere about 4-hour mark, but it may well be somewhat shorter than that. So next bit, we've got our drugs in. So what do we need to keep an eye on? The one thing we want to keep an eye on is that we don't cause a mechanical obstruction because we give the patient too much fluid. So limit the fluid to 500 mils. Don't put 1 litre bags up for day surgery. And patients do not routinely need a catheter. Now, this is arguably, no, next slide is going to be arguably one of the more important slides, but this is a very old paper, and this actually paved the way for our own bladder management pathway within our department. And I'll show you that pathway in a second. And we have not encountered retention from a spinal with patients which don't have any other risk factors, so low risk patients, so the fit, healthy patients having knee arthroscopy, we've not caused retention because of the spinal. And we are strict with the fluid, but not too strict. So if a patient needs fluids, by all means, give it to them. In terms of the bladder pathway, low risk patients, we've actually said, and we've said for quite a few years, well over 10 years, they don't have to void before they go home. And it's the more at-risk patients where we actually have to be a little bit more careful about. Now, don't worry about all the details which is in this slide. There's a more abbreviated, shortened version in the handbook, much more simple. The main thing to really kind of take home from this is we've got a risk factor stratification, so what puts someone at risk. And if they're at risk, the main thing that we're going to be doing is, can you void or can you not void? And then ultrasound scan of the bladder. And the addition that we've made to our bladder management chart is actually asking for an international prostate score for certain patients depending on what way they go. It's quite fun. It's a talk all in its own right, and colleagues in my department actually presented this at BADS last year. I've put my Twitter account here, and I've got this like this picture on my Twitter account. But also, if you want to find out more, and I can give you the presentation we gave to BADS about this very thing, email me. My email's coming up in a second. Or just look in the handbook for the more abbreviated version. But really get something like this in place before you're doing lots of spinals within a day case environment. So next point is thinking about hypotension and other mischief that spinals can cause. Maintain venous return, and whatever you do, don't sit the patient bolt upright, because you will come to mischief, as the idiot has experienced once before or twice before. We looked back at our last 100 patients, and I'll go through what we found. We had one very impressive vasovagal episode in recovery, which looked more like a kind of nasty basal gyrus reflex of horribleness. And basically, the patient had been sat bolt upright immediately after coming out of theatre. You've got to treat this anaesthetic with the same degree of respect as you would a general anaesthetic. So just because it's local and the patient's chatting to you, you've still got to be quite vigilant. So the patient still might need some form of glycopyrrolate, metronidazole, or even ephedrine. And I'll say again, avoid dehydration and avoid the sitting up too quickly. And so we want to keep them wet, but not too wet. So just somewhere in the middle. So 500 mils is quite nice. So when can a patient go home after a spinal anaesthetic? Early on, when my predecessors really kind of worked on this within our department, the thing that they looked at was straight leg raise. Now, the problem with that is motor is one of the first things to come back. And actually, you can straight leg raise, but if the sensation and proprioception haven't yet come back, and they do come back later, you may well get into a muddle in terms of instability. So check sole sensation and check proprioception on the big toe, and then you won't get into mischief. And then lastly, like we do all the time, we audit everything. And if you're going to introduce this into your practice, I'd say Audit. It's quite a cool project for any juniors that want to kind of a project, or anyone else that wants a project. But I would really advocate the follow-up. And what we do in our department, and I don't know if Robbie will add in later what he does, but we follow up all our patients in day surgery who have had any kind of block. So any upper limb, lower limb block, they get a nurse's phone call the following day, or if they can't get through the day after that. And this includes spinal anaesthetic. And it's the usual kind of questions that you would be asking the patients that have had a obstetric spinal anaesthetic. So have you got a headache? Have you got any problems with your legs? How's the bladder doing? And then all the kind of like the nice questions as well in terms of would you rate your anaesthetist? No, it's would you have this anaesthetic again if you got the chance? Which is quite cool. So I really kind of advise going down this route, having some form of follow-up and getting that in place. So yeah, last bit, right at the end of the infographic is basically a hyperlink to the handbook that Robbie, myself, and everyone else is basically making reference to. So it's a nice resource. And I see Amit, so my time is up. Sorry, Amit. This is me. That's my email. This is recorded, so you'll be able to get my email later on. That's what I've talked about. And the main message is keep it simple. You've been great.
Ben, thank you very much. And just for the audience, I just wanted to highlight Ben designed that whole infographic himself. So he put a lot of thought and effort in that in order to distill the core principles that we all wanted. So Ben, we really appreciate you doing that. As we are getting towards the end of the webinar, I'm going to basically take a couple of questions that have come up, which are probably most relevant. Any tips and tricks to get the surgeons on board? A lot of them in our institution struggle with the idea of spinal blocks and having patients awake during surgery.
Taking the example I might have mentioned, I can't remember if I did, but the knee surgeon that I commonly work with, he doesn't have that follow-up outpatient appointment, and so he argues it's a much better quality of care for the patient, but also he then actually just gets to see new patients. He's not doing a follow-up clinic just to see patients where he knows, well, trying to explain something he did a few weeks back. He's able to give all that information there and then. Obviously, some surgeons might not like that. They might like the kind of easy life of just doing lots of like follow-up outpatient appointments. In terms of the patients being wide awake, I think that the easy thing to do there is to perhaps add in some sedation. I know that it's a bit of a contentious topic, but if it means that the patient's going to be, well, it means that the surgeon's going to be a bit happier, a little bit of sedation will just kind of help to grease the wheels.
Thank you, Ben. And I think the last question, there are so many questions, so I think we'll probably email them to you to see if you can give us your answers, then we'll email them out to all registrants afterwards. So how do you go about mobilizing the patients? Do you have specially trained nurses for doing that? So you wait for hallux proprioception, straight leg raise, and sole sensation, and then you just get them up safely, or slowly, or is there a specific pathway you have?
Yeah, we don't have a pathway, but basically, the guys in our department have been doing this for about 16 years. So I think the first BADS handbook was published, I wrote it down actually, 2004. And so it wasn't just the anaesthetist, it was the nurses with this as well. So it's almost been like a kind of a hand down through generations of what to do. And so basically any time the patient's going to get up to move, the nurse will be there to actually assist them. And as you said, that there is criteria that the nurses will assess before the patient is actually mobilized.
Perfect. Ben, I think we're going to call it a close there. So thank you very much for that.